Hello and welcome to this webinar on chronic pain. Veterans in Pain, Where the Body and Mind Meet, which I think is a very nice little title and I think foreshadows a number of issues that we're going to be looking at this evening. A very warm welcome to all of you who've joined us tonight for the live activity, and the numbers are extraordinary. We had nearly 2,500 people register for this webinar. So that's, I think, a testament to how important this issue is and perhaps how challenging we as clinicians find it. A warm welcome also to those of you who are watching us later on a recording, and of course a very warm welcome to our panel, who I will introduce in just a moment. First, I'd like to acknowledge the traditional custodians of the lands across Australia upon which our panelists and our participants are located. And I'd like to pay our respects to their elders, past, present. My name's Mark Creamer. I'm a clinical psychologist, and I've had a very long interest in the mental health effects of trauma, and particularly in veteran and military mental health. And in my clinical practice, it's not at all unusual, of course, for me to see people who have chronic pain in addition to a mental health problem. And I have to be honest and say that I always find it challenging and often difficult to work with those comorbidities. And so I'm thrilled tonight to be able to facilitate this panel and to be able to pick the brains of our expert panelists. So without further ado, let me introduce them. You've all had copies of their bios, so I'll keep it very brief. First, I'd like to introduce Meredith Craigie. Meredith is based in Adelaide, but is coming to us tonight from Darwin. Meredith is a specialist pain medicine physician based at the Queen Elizabeth Hospital in Adelaide. She's an anaesthetist, and she initially specialized in pediatric anesthetics. And she developed her interest in pain when she was working with children on a burns unit. Great to have you with us tonight, Meredith. Thank you very much for joining us.
My pleasure.
I must say that sounds as though it would have been a pretty heavy, pretty tough kind of job, the child burns unit.
Well, it certainly had its challenges, but in some ways somewhat similar to the challenges our veterans face, in that having a burn is a very traumatic experience, and unusual for the children to develop psychological sequelae, post-traumatic stress disorder, and of course we don't often notice that in children. So I think there are some parallel challenges with medications, trying to get the whole family functioning better again as the child recovers from that injury.
No doubt we will pick up actually on a whole range of those issues that you've highlighted there. Well, I'm also interested, though, well, I'm going to ask all of the panel this, actually, about whether there's something that you do to kind of get away from work into a completely different role. And I've heard it through the grapevine that you are actually a bit of a gardener. Is that right?
I do enjoy getting my hands dirty, and it's, that reconnection with nature and having some time to myself to just mull over issues. But these days, I just have to do it in little pots rather than my big garden as we downsized our house. So it's still quite pleasurable.
Okay, but a different kind of level, yeah. Anyway, thank you very much.
I'm a potty gardener.
Yeah, okay. And I've got a sneaking suspicion we might be talking about pot again later, but anyway, we'll come back. Thank you very much, Meredith. Thanks again for joining us. Our next panelist is Catherine Nicholson-Perry. Catherine is a clinical psychologist. She's particularly interested in health, disability and rehabilitation, and especially interested in the psychological management of chronic pain. Catherine is currently a professor in the Australian College of Applied Psychology in Sydney. Thanks very much for joining us, Catherine. Welcome.
Lovely to be here.
And I was just talking, as you heard, to Meredith there about things that you can do to get away from work and so on. And I hear through the grapevine that you're a bit of I was going to say a cat woman, but that sounds a bit like a superhero of some kind. Maybe
less
not cat
woman and more crazy cat lady.
But you do like cats, is that right?
I do. I have 4 cats, which is not bad in a 2-bedroom inner city apartment.
I'd say it's very impressive. And do they help you unwind, do you think, after a tough day?
Yeah, they certainly do. They certainly do. I love to just hang out at home with them in the evening after a long day. They're very restorative.
Good. There's increasing evidence, I think, isn't there, about the mental health effects of pets. So great.
Absolutely.
Okay. Thank you very much, Catherine. Our final panel member tonight is Mal Hopwood. Mal is Director of the Professorial Psychiatry Unit at the Albert Road Clinic, and he's also a Professor of Psychiatry at the University of Melbourne. Mal has a particular interest in depression and anxiety, and also in acquired brain injury. And he has a huge amount of experience working in veterans' mental health. So it's really good that you could join us tonight. Mal, welcome.
Thanks, Mark. A pleasure.
And we've been talking about things that you can use to kind of de-stress. And I'm wondering, I suspect this is not always a good way of de-stressing for you, but I happen to know that you're a bit of a Richmond fan. And I guess at the moment you'd be feeling pretty good about how they're going in the football.
I am feeling pretty good with life, but seeing last year was their first premiership for 38 years, I've had to learn resilience, put it that way.
Yes, that's exactly right. We spent a lot of time feeling sorry for Richmond supporters. All right. Thank you very much indeed, Mal, and welcome to all the panelists. Let me just take a minute. Oh, that's not the slide I was expecting there, actually. Here we go. Yes. So let me just take a minute to tell you about this webinar series. This is actually the 8th in a series of DVA commissioned webinars on veteran and military mental health. So last year we looked at military and veteran culture, we looked at PTSD, we looked at anger, substance abuse, sleep, families, and earlier this year we looked at suicide. And if you missed any of those, they're all available on the DVA at Ease website, and I'd strongly encourage you to look. This is an ongoing series, and we hope there will be another 6 webinars before the end of next year. Let me just give you a very quick orientation to the webinar platform. Well, I'm sure you all know it. There's a chat box down in the bottom there called Open Chat tab if you want to talk to each other or send us a message while the thing's going on. There's a resource library, which you don't really need to worry too much about tonight. It's got the slides in it and a whole range of other resources. But we will send you a link to that in the days following the webinar, and you can look at all the resources then. And there's a tech support tab as well. So I'm sure it's all fairly straightforward. And I do want to remind you before you log out to complete the exit survey and to let us know what you thought about this particular webinar platform. But tonight, we're looking at chronic pain, both in isolation and in the context of a coexisting mental health problem. And we're doing it particularly in the context of veteran and military populations. And we're going to use our case vignette as a kind of jumping off point, a way of highlighting some of the key issues. I think you've all had a chance to read Janelle's story. That came out to everybody, and I'm sure that it rings a few bells for many of you. We're going to use Janelle's story as a way of exploring some of the issues around chronic pain, and each of our panelists is going to give a brief talk to us about their unique perspective on the issues raised by Janelle's case, and then we'll open it up for questions and discussion. And at the end of the webinar, of course, we hope that you'll have a better understanding, I guess a better understanding of the mechanisms that underlie chronic pain, but also the relationship between pain and mental health, the risk factors, the warning signs, and so on. We hope you'll have a better understanding of the available treatments, the most efficient evidence-based treatments for treating chronic pain, and that as a result of both of those two, you will have some increased confidence in working with veterans when they present with chronic pain and coexisting mental health issues. So without further ado, I'd like to hand over to our first panelist, Meredith, to talk to us about her reactions to Janelle's story from the perspective of an anaesthetist and a pain specialist. Over to you, Meredith.
Well, thank you very much. We've got a very interesting case here, but it's not an unusual situation. Janelle is certainly at a pretty low point in her life, and she's suffering not just from knee pain, from pain in many parts of her body now, and altogether that's preventing her from enjoying her life. So how her specialist pain medicine physician might fit into this is to sit down with her. Usually we allow an hour to take an initial history, to really let her tell her story and tell us how it's been affecting her life. We like to do what's known as a pain-oriented physical examination, and then work out a pain management plan in collaboration with the other specialists who might be looking after her. And that might require quite a team of people who might have backgrounds like our other presenters tonight, psychologists, psychiatrists, but also maybe a physical therapist, and clearly a general practitioner will be pivotal in helping her manage everything. So she's feeling quite confused about what's going on here. So let's look at how we can help. So the first step really is for Janelle to understand her pain a bit better. The evidence shows that the first step on the road to recovery is understanding pain processing a bit. And so this is a pretty simplistic diagram, but it allows us to get the picture of the complexity of pain processing, starting with that initial trauma that was from the fall on her knees, which sent a cascade of electrical impulses into the spinal cord, and from there up to the brain stem and the thalamus, and from there a fanning out of electrical impulses over the whole brain, more or less, so that all the various brain areas can do their task in helping Janelle very rapidly answer questions like, where is that impulse coming from? What is it? What does it mean? What do I need to do about it? Do I need to pay attention right now? Is there a memory of some similar event? And will that help me work out what to do about it? Her stress response is activated because maybe she needs to take some action straight away, and that might require physiological changes happening. And all of this processing occurs in a fraction of a minute and appears in Janelle's conscious mind as an aversive experience, a warning of danger. And generally we use the term pain to describe that. She's localized it to her knees, and so she might even look at them and start to work out what she needs to do to address the issue. And clearly in her first experience, she was a bit embarrassed that it happened. She tried to ignore it. But there are other influences driving her decision to try not to pay too much attention at that time. One was the context. So the fact that she's in the armed forces and she's got to be tough. Maybe her past pain experiences influencing that. Also her genetic inheritance might influence some of that processing and perhaps the severity of that pain experience. We know early life experiences can be important as well. So there's many factors that can influence that experience. And there are also downward descending modulatory pathways that can either amplify or dampen that down as well. So we're starting to get the idea that pain processing isn't quite as simple as we might have thought. But when we have recurrent injury or inflammation, we get a whole new wave of activation in the system. And this is actually occurring in the immune system and mostly in the glial cells in the nervous system itself. Glial cells are immune-like cells that actually have an important role in maintaining the integrity of the nervous system, and actually they engulf the synapses and control neurotransmitter release, both pre and post-synaptically. Microglia are particularly important because they maintain the reactivity and hyperexcitability of the synapse. In chronic pain, there's a fundamental reorganization in response to the persistent stress, recruitment of maladaptive microcytic and glial processes. And also we now know that we get peripheral T cell movement into the nervous system as well, which can all change that trophic support and release pro-inflammatory cytokines, which actually modifies that neural processing that is going on. So we could suggest that pain pathology resides largely in the glial component, but it's expressed as adaptations in the neuronal system. That all sounds kind of complicated, What we do know, though, is the flow-on effects are that we see changes in the grey matter in the brain on fMRI scanning. That all sounds a bit gloom and doom, but if we try to make it a little bit more understandable for Janelle, we could suggest to her that those nociceptors could be considered to be danger sensors. They're not pain sensors. We don't process pain in the periphery. It's all processed in the brain. And their involvement of past memories of danger, and that's where her other experiences in the armed force might come into play, the context in which the experience occurred, and then ultimately the balance between these danger signals and signals of safety that might eventually produce Janelle's personal experience of pain. All these changes in the nervous system occur because of a process known as bioplasticity or neuroplasticity, and that underpins the adaptability of the nervous system. So that's a really useful piece of information, because that means that the system can be changed by the input that we deliver with our treatments and with subsequent experience. So when we look to working out a pathway to Janelle's road to recovery, we can say to Janelle that change is possible and that she can get better. And what we want to do is build on late 20th century models of understanding pain, which was this biopsychosocial model, which was a big improvement on everything else and allowed us to recognise all those emotional and contextual elements of pain. But still, I think people weren't very accepting of the importance of those elements, and there was still a significant emphasis on medications and interventions for managing pain. What we've done more recently is kind of flip that paradigm to some extent, recognising the importance of the psychological elements in that pain experience, and also the social elements. And I think a bigger emphasis now in this more socio-psycho biomedical paradigm around the importance of psychological therapies, addressing social stressors, as well as perhaps some emphasis on a physical rehabilitation, which is more about functional improvement with medications and a different range of medications, and very, very occasionally interventions or further investigations being needed to help manage that pain. So I think as we look at what's happening for Janelle, it is clear that the psychological and social elements are very important. So I'm going to hand over to Catherine to talk about her perspective.
Thank you very, very much indeed, Meredith. That was a fantastic overview, and sort of gave us an understanding of all the mechanisms underlying it and the multidisciplinary response. I want to just come back to that sort of half-joking comment I made earlier, and you talked about a few medications there. I'm sure that you could talk for days about this, but we've heard a lot about the role of cannabis in managing pain. So just very quickly, what's the take-home message about that now? What's the current thinking on cannabis?
Well, everyone will find some fantastic resources on the Therapeutic Goods Administration website, but the bottom line is that the products that have been investigated so far have not really been proven to be useful in managing persistent pain. They may have a role in neuropathic pain, but on the whole, the numbers needed to treat that, how many people do we need to give this medication to for one person to get 30% pain relief, which really isn't very much, is actually 22. So that's a pretty underwhelming number. What we need is better information about the products that are currently available on the market, and we look forward to seeing that. We also need to understand better exactly in what circumstances will we use it. And there are a number of trials going on in pain and mental health areas, looking at the use of cannabis for managing some forms of anxiety, for instance. So I think we're at a point where it's an interesting concept, but the evidence to date is not supporting its use.
Yeah, okay. Thank you very much for that, but it does sound as though we should be watching this space as we go into the future.
I think so. Watch the space.
Yeah, and maybe, if depending on how time goes, we might come back to that and talk a bit more when we talk about self-medication, which is a big issue. But for now, as Meredith alluded to there, it's time to move on and think a bit more about the psychological approaches to treatment. And so it gives me great pleasure to hand over to Catherine to talk about psychological management of chronic pain. Catherine? Are you on mute, Catherine? We can't hear you.
Now I'm not. How's that?
Ah, now you're not. That's better.
I was just saying thank you very much to Meredith for setting things up well for me, because it's almost like we've done this before. It leads in very nicely, I think, to the psychological perspective on chronic pain. And I just want to start out by saying that I'm going to leave aside the issue of the kinds of specific mental health problems that can accompany all sorts of chronic medical conditions. I know Mal's going to talk a bit about that in a moment. So, and I really want to emphasise the fact that, especially given we know how much of the processing of pain happens centrally in the brain, that for any of us to experience pain, there are psychological processes that are involved. So we shouldn't think about psychological issues in the context of chronic pain only when we are stumped from a medical perspective in terms of understanding why someone might have a particular pain problem. It's important for anybody, and therefore potentially anyone who's struggling to deal with a chronic pain problem may be helped by working with a psychologist or applying psychological principles. Meredith identified the origins of the biopsychosocial model and the way in which that's been kind of maybe reconceptualized over the years. But essentially, I think it's a really interesting way of giving people an entree into thinking about the psychological perspective. It's not a competition between the processes of nociception and neuropathy and psychological processes. It very much acknowledges the way that those things work together. But it allows us to think of some of the additional layers of the onion, if you'd like to think of it that way, that might influence the way that somebody who has a pain problem presents to us when we're working with them. So that includes processes around the perception of pain, the kinds of attitudes and beliefs that people might have, and there's some very particular ones that can be very influential in terms of predicting the levels of psychological distress or suffering that somebody might experience, and how they cope, I'm just going to back to the previous slide a second, and the kinds of coping responses that they use in response to their the pain perception, as well as the way those things are reinforced in by the social environment around them. So the kinds of attitudes and beliefs that we know play a key part in predicting the extent to which an experience of pain is related to both emotional distress as well as levels of disability include things such as pain catastrophizing, which is essentially the extent to which somebody is focused on the most negative outcomes of pain. So that might be things, for example, like Janelle, about wondering to herself if she's feeling the way that she's feeling now at the age that she is, how is she going to cope as time goes on? People often assume that their pain condition is going to deteriorate over time, and they become fearful and anxious about what the future might hold, very understandably. Pain self-efficacy is another very important psychological concept, and that's the extent to which people feel confident to be able to get on with activities of daily living despite having a pain problem. So it's not about what you think you could do if the pain problem could be solved, but what you feel you're able to manage despite the pain problem. And I guess there are different ways in which a career in the armed forces might impact on those different types of attitudes and beliefs that are so important in predicting outcomes. So you might have a group of people who might have beliefs, for example, such as no pain, no gain, which might mean that from a behavioural perspective, they're quite inclined to sort of push through and just try and keep going and ignore signals that there may be something that they need to pay attention to. They may also be concerned that if there is an underlying major problem, that may result in them being discharged from the services, that they would be concerned about losing all of the social support and networks, etc., that participation in the services can offer to people. In terms of coping and pain behaviour, there are essentially two major patterns of pain behaviour which can be problematic in people with chronic pain. Many of the patients who present to chronic pain clinics are predominantly what we would refer to as underdoers. So people who respond to pain by cutting back their level of activity, and that's often based on a perception that if you're experiencing pain, it's an indicator that there is that you're doing some kind of damage, and that to avoid doing the activity is likely to reduce the damage and therefore reduce the pain. However, what we know from people who are caught in that kind of that pattern is that what tends to happen is actually that they end up becoming deconditioned and finding physical activity harder and harder, and therefore it's easier and easier to trigger an increase in their pain. So it's actually almost becomes a nasty catch-22 for them. The other group of people are those who overdo, and I think my experience has been working with some veterans along the way who have had chronic pain problems, but also members of other services, and also actually elite athletes, is that often they are so used to persisting, they're so goal-oriented that they're actually more likely to overdo. And so as a clinician, much of my work has been done with groups of people with chronic pain problem, and I've found myself having to balance up in groups, reining in some people, asking them to kind of slow things down, and encouraging some people to kind of up their levels of activity. The other coping strategy that people often use, which can also create a problem for people, is getting into the habit of pain contingent use of strategies such as medication use. So, and this can set up a pattern of conditioning whereby somebody starts to believe that all of the benefits or periods of time when they have less pain are a direct result of the medication that they're using and none of the other strategies that they might be applying. And so often one of the common issues that I'd be working with someone on in the very early stages of their pain management intervention from a psychological perspective is to get into the habit of using things like medication on a time contingent rather than a pain contingent basis, to try and make sure that the pain is well managed in the background and there are fewer episodes of breakthrough or flare-up pain. So then we come to the social environment, and I guess from Janelle's point of view, she's lost potentially what she saw as one of her main social supports in terms of her husband, but also has lost the support around her of being employed in services. We might also think about what some of the attitudes and behaviours that her social environment up until this point have reinforced to her, and it's very clear that she's been quite perhaps avoidant of talking about these issues with people or admitting to them, and that may be due to concerns about how she might be judged or evaluated and the consequences in terms of her career. And social support, just with as with very many other kinds of medical conditions and mental health conditions, is a very important piece of jigsaw, if you like, in terms of trying to help people to maintain their well-being in the face of an ongoing chronic condition. So certainly having access to and giving some thought to the kinds of social support she might be able to engage with is going to be a very important part of any kind of a recovery plan for her. So I know that obviously psychologists are often thought of as those for whom the psychological is the most important thing, but I think it's really important to remember that the whole team in dealing with this client Janelle as a person are going to be engaging with the kinds of psychological issues that may be impacting on her experience of pain and her ability to cope with it effectively. And I think one of the most important things in this regard is to communicate very clearly to her that everybody understands that the pain that she's experiencing is a real pain, that there's no such thing as psychological versus physical pain, and trying to accommodate the way that they might interact with her to try to reinforce effective and helpful coping strategies. So, for example, pain education, as Meredith pointed out, is incredibly important to set up the person to be able to engage with psychological and other kinds of interventions effectively. It's not necessary for people to understand all of the information that Meredith provided for us earlier on. I often tell my students here at ACAP that the important thing is that the client has a working model of understanding their pain that allows them to interact with the interventions that are being offered to them in a helpful and constructive way. Low self-efficacy, for example, might suggest that people like physiotherapists might need to grade up someone's activity more slowly. They might need more reinforcement. They might need to be helped to see how they can set goals for themselves and help to kind of direct their own upgrade of activities to help restore that sense of control. And that you might have to make a bit of an assessment of whether you think your client is really an overdoer or an underdoer, and then think about the kinds of ways that you might need to structure your intervention with them based on that kind of profile. So maybe really encouraging the person to make small increases every day, to plan for those increases, to find ways of reinforcing themselves for doing that in the underdoers. And in the overdoers, to try and encourage them not to do more because they feel like they can do more on the day, to just stick to the targets that they've set for themselves, to try and maintain a steady level of activity and avoid some of the major increases in pain that can come about as a result of that.
Thank you very much.
I think that's me done.
I think it is. Thank you very much, Catherine. That's fantastic. And I guess just I'm thinking to ask you to kind of, if you were to pull together that into like a few key, just 2 or 3 or whatever, key points about what you think is the key essence of a psychological intervention with chronic pain, what would the dot points be, I suppose?
Yes, okay. So there's a large body of evidence about the effectiveness of psychological interventions, which originated really with cognitive behavioural therapies. And probably there's some emerging evidence around some of the other related kinds of interventions like acceptance and commitment therapy, for example. And generally speaking, the outcomes are pretty similar, whichever of those interventions you decide to apply. Most of the data, however, is based on kind of gold standard interventions, which are about 100 hours of contact time, often between an interdisciplinary group of professionals and the individual client. So, whole package of graded exercise, pain education, etc., are all being tied together. So, as an individual psychologist, if you're working with clients, I think you can really certainly translate the basic components of cognitive behavioural therapy in all of its various different sorts. Identifying goals that the client wants to work on, is motivated towards making sure that you do a good job of pain education and helping them to get the understanding that they need to open the door for intervention. Looking at pacing their activities, so trying to get a steady level of activity rather than peaks and troughs of activity, and really trying to tackle some of those unhelpful cognitions like pain catastrophizing or low pain self-efficacy that can really get in the way.
Yeah, that's great. Okay, thank you very much indeed for that, Catherine. Much appreciated. Let's move on.
Pleasure.
And let's now get a psychiatrist perspective from Mal. Over to you, Mal.
Thank you, Mark. So what I'm going to address are what are some of the common psychiatric comorbidities we might see in this situation. I want to start by saying, of course, not everyone with chronic pain has psychiatric comorbidities, but a greater proportion of people will than we see in the general population, and it's very important that we're aware of these comorbidities and actively involved in looking for them. Because Janelle's a veteran, immediately our mind might turn to trauma-related pathology such as PTSD, but lots of studies show us that the commonest psychiatric comorbidity in association with chronic pain is depression. This is data from the Global Burden of Disease study that I'm sure many of you are very familiar with, and actually the most recent estimates tell us that unipolar major depression will be the leading cause of disability globally by 2025. It's not new news, but at a population level, that translates to if someone like Janelle is presenting to us with a chronic health problem, including chronic pain, the odds are getting close to they're as likely to have depression as not. And many surveys suggest somewhere between a quarter and a half of people presenting to a chronic pain clinic will meet criteria for major depression if you ask them all the right questions. It's kind of important in saying that, therefore, somewhere between a half and three quarters don't meet criteria for major depression as well. But sometimes we can get caught in the trap of assuming, excuse me, well, because you've got chronic pain, of course you'll be depressed, and therefore we'll not sort of focus on that as a problem in its own right. That would be a shame and a mistake. So any patient presenting with chronic pain, part of the systematic review should be a good look for symptoms of depression. If we think specifically about Janelle then, she describes a number of symptoms that I think could be taken as suggestive or hints towards the possibility she's depressed. So she's described the development over time of lethargy, withdrawal, amotivation and self-doubt. And I do wonder if the self-doubt to some degree is not an exacerbation of a style she may have already had. If you look at the risk factors for depression that Janelle has, she's a recently separated person, a woman with, we all know the epidemiological risk for depression is higher in women by a ratio of 2 to 1. She has chronic pain. I suspect reading the vignette she may have perfectionistic and driven traits. We know that these can be an advantage in many dedicated people who serve in the ADF, but can sometimes not be an advantage in other situations. She's had a significant loss of role and has really struggled to re-establish herself. And I was left wondering a little bit about a possible role of substance abuse. But if I just focus on the depression for a moment, there are strong reasons to think Janelle is at high risk of getting or may already have depression. And clearly this needs a close evaluation. That means appropriate systematic questioning of the usual kind for the symptoms of depression, and not relying on the assumption that things such as lethargy or withdrawal are automatically a direct consequence of the pain itself. They may be, but a close examination of time relationships would be helpful. Substance abuse can, of course, be both a comorbidity of depression and chronic pain and a problem in its own right in people with chronic pain. And often the thought turns directly to substance abuse of those things prescribed for the treatment of pain, and obviously particularly the opiates in recent times. And whilst that focus is entirely appropriate, it's equally important to emphasise that some of the things that individuals with chronic pain might abuse might be exactly the same as the rest of the community and include things like alcohol. So certainly in Janelle's case, a close questioning about her level of drinking would be an important part of my further evaluation. I think it gets missed relatively easily in this population. Of course, Janelle does have a history of exposure to trauma in her role in the ADF, and it would be inappropriate or unreasonable to ignore that. So is Janelle's role, does her historical role, I should say, place her at risk of the development of PTSD? Yes. If PTSD is present, will that interfere with the management of chronic pain and vice versa? Very much so. She clearly has the kind of experience when she was in Afghanistan that meets the criterion A for the development of PTSD. There are some interesting components of that experience that are likely to increase the risk. Somewhat mixed and potentially at times morally conflictual nature of her role. There's lots of evidence from a range of traumatic situations that having a role in handling body parts creates a higher risk. And indeed, in the individual with injury, whether that injury is part of the same trauma or separate, where pain can act as both a trauma reminder and a provoker of re-experiencing phenomena. So Janelle is an individual at risk of PTSD. Part of our evaluation needs to be a close look for symptoms of PTSD, an acknowledgement that she may choose, of course, not to reveal those, when we first see her, and that the combination of chronic pain, major depression and PTSD, plus or minus substance abuse, is not, in my experience, an uncommon one in veterans, and adequate treatment of each of those components will be a vital part of actually getting to help Janelle effectively. If I can just, I think, emphasise something in a slightly crude way that Catherine said. What I'm not thinking is this pain all in her head or not? It is indeed one of the most unhelpful questions to ask. The answer is yes and no. So, as Meredith outlined beautifully, of course, pain ultimately comes from somewhere, and it's a centrally mediated phenomena. But generally, when people are asking this question, what they're saying is, can the pain be explained solely in terms of psychopathology, or does it have some identifiable physical cause? Assuming that we can make a final answer to that really defies our current level of knowledge and capacity, and also, I think, generally defies the reality for most people. In particular, the concern with this question is that if Janelle senses that we are having that thought, my experience that she's very likely to see that as quite a devastating rejection, one that she may well have already felt that she's experienced on more than one occasion by the time she comes to see some sort of specialist service or some sort of clinician. And she would no doubt experience that as disempowering, discriminating, and really coming from a spot not designed to help her. It shouldn't be necessary to say that, but I think it's important to acknowledge that within our healthcare systems, people do still implicitly get that message at times. We need to be sensitive to that as clinicians, be very mindful about how we put our interventions to avoid getting into that trap. Thank you very much, Mark.
Thank you very much indeed, Mal. Very, very much indeed. A whole range of issues there that I think we will be picking up on later. We are running a little bit behind time, so I think if you don't mind, we'll move straight into the discussion. But I'm pleased to say that the speakers in their presentations have already answered many of the questions that you've sent in. So I was happy to kind of let it go a little bit and perhaps cut the discussion short a bit. I must say that I've been very impressed with the number and quality of questions that you have sent in for us and for the panel. And I know that there's plenty coming in now. We're seeing on the screen as we talk. So we'll try and get to as many of those as we can, but I can't promise that we'll get to all of them. In order to help us kind of work out what you think is important, we're going to run a little poll. So what we're going to see on our screen here, as soon as I can find it, is the themes that have been identified in the questions. So we've summarized your questions into 5 broad themes. We've got overuse of medications there, self-medicating and substance use, influence of military culture, link between chronic pain and mental health, and responding to the somatoform disorders. Now, I was going to ask Gianno to start the poll, but he's already done it, so you haven't got long to go. If I can ask you just in the next little bit of time to whack in your votes on which ones you would like to see us talking about, that'll be great. And I can't promise that I'm going to talk about them in exactly that order, because sometimes it makes more sense to talk in a different kind of order, but we will make sure that we allocate plenty of time to the ones that you choosing. So, okay, I think we'll probably wind it up there. So if we can close off the poll, Jono, and perhaps put the results up on the screen for everybody. And according to mine, the one that comes up the most, although all of them are getting a bit of a rating, but the one that comes up the most is the link between chronic pain and mental health, and particularly PTSD. And I think it's a really important one to be having a look at. So let us go on and look at some questions and answers in that area. And I guess, one of the things that I suppose we're inevitably talking about with veterans is the idea of trauma. And I might just bring you in, Meredith, if I could. Thinking about how unresolved trauma and PTSD, if you like, might influence the treatment of pain when you're talking about pain specialists, and whether they would be sensitive to that, whether they take that into account, how that might influence their treatment?
I think pain specialists are very aware of the influence of past trauma, both in terms of physical trauma, for instance, Janelle's situation in the ADF, but also childhood trauma. And there's some evidence that those traumas actually change the stress response, and it almost leaves the system on high alert, as it were. So it's a way of amplification of all of the processing that I was talking about beforehand. So they're really important to address the two things together, and in my mind they can't be really separated out into separate issues. They're all part of the same broad constellation of symptoms and signs that the person might be experiencing. So often we find pain is hard to manage if are using strategies that don't incorporate those psychological approaches, recognition of the psychological trauma, and my understanding from my colleagues who are more working in the psychiatry arena is that mental health issues are hard to address if we don't address the pain. So we end up in a bit of a chicken and egg situation. But it's important to have that big understanding.
I think it's a really important point, isn't it? That presumably it is a chicken and egg thing, and if we can manage the pain more effectively, that's going to help our mental health. And if we can manage the mental health more effectively, that's also hopefully going to help the chronic pain. So it is I think a chicken and egg thing. If I could bring you in, Mal, can you just speculate a bit, if you like, on how you think the presence of chronic pain might influence the treatment of PTSD? If we've got a veteran with PTSD and chronic pain, does that alter the treatment approach that we're going to use?
Well, I think following on from Meredith's comments, I think it does alter it by acknowledging the need to expand the treating team so that you've got skills and capacity to address the issues of chronic pain simultaneously. Because if that's not done well, addressing PTSD is only going to be harder. I think the next step is acknowledging the interaction between the two. It's particularly poignant when the injury that causes pain may also be the primary trauma that's associated with PTSD. Because we can see for some people, their pain really acts as a trigger in its own right. And that's quite a complex clinical situation. In managing chronic pain, good medication management is very important. So over pharmacological management, if I can use that, is going to make things like exposure-based therapy practically impossible. Doing exposure-based therapy with a patient who's on very high levels of opiates, for example, is really practically very difficult, both because of sedation and potentially because of the person's capacity to reach the level of arousal you might otherwise like. Of course, there may be an interaction around the pharmacotherapies for PTSD and depression and the use of antidepressants, and we can explore that more if needed. I think central to getting it right is acknowledging the interplay. So at times in our approach to trauma-related psychopathology, we focused on the meaning of pain, its role in psychological symptoms, and how we'd understand it psychologically, and actually forgot to get on with treating the pain in its own right. And that would be a grave mistake.
Yeah, absolutely. And of course, we are talking specifically tonight about veterans and so on, but the kind of things that you were saying there and that Meredith was saying before about trauma, of course, apply equally to a whole range of other populations. And certainly Meredith was talking about child burns, but also our refugee population, for example, and our survivors of violent assault and a whole lot of other groups. These same issues would apply, wouldn't they?
Even motor accident victims, for that matter.
Yeah, absolutely. I was wondering if I could bring you in, Catherine. I guess and pick up on something that Mal was saying there, really, which is about the relationship between chronic pain and PTSD and the extent to which they might feed into each other. We've got a question that someone sent in, actually, specifically asking about the kind of tension, bodily tension that's often associated with PTSD and whether that's going to feed into chronic pain and how they interact. Have you got any comments on that?
Yeah, I mean, I agree entirely with what Mal and Meredith have said already. I guess these things, neurons that wire together, wire together rather. So these, particularly where these events have given rise to both the chronic pain and the PTSD experience, often they become part and parcel of the same kind of syndrome. So an exacerbation in chronic pain may be part of the experience of the PTSD, and likewise a flashback or something along those lines might be enough to trigger off an exacerbation of the chronic pain. And that makes it a highly complex situation to try to deal with. And of course, both conditions are essentially require a degree of exposure for their treatment. And of course, exposure is can be a very confronting thing to get involved with. And so where you're essentially putting yourself as a client in a position where you're exposing yourself both to the experience of chronic pain as well as some of the symptoms of the PTSD itself, that's asking a lot, unless the client feels that they understand the purpose of it, they understand the rationale, they've got a good therapeutic alliance with the clinician that's working with them. But I do think that it's very important to treat those things as one related set of issues, because I think it helps the client to think of this as a single issue that can be dealt with, rather than thinking of them as separate issues that all require separate solutions. And many of the skills that you might help someone to learn to deal with chronic pain can be applied to managing PTSD and vice versa.
Yeah, absolutely. And I remember, as you were talking, a paper that I found very influential that came out a while ago that talked about PTSD and chronic pain being kind of mutually reinforcing, as it were, and that people end up in this kind of downward spiral, exactly along the lines that you were talking about.
Yeah, absolutely. And I think often for clinicians, it's for clinicians who are perhaps very used to working with PTSD, clinicians can be pain catastrophizers as well as clients. We're often worried about what might be going on if the clinician is not kind of suitably assured that there's no major underlying problem that needs medical attention. They can find it difficult to kind of be confident enough to pursue exposure-based treatments that are going to be important for the management of the PTSD, because of anxiety about the way that may influence the person's perception of their pain, at least in the short term.
Yeah. And look, I take your point about essentially treating them at the same time as being important, but I'd like to throw that question to Mal and to Meredith as well, because a few people have written in saying, what about sequencing? Should we be trying to do something about the pain first, or should we try and do something about the mental health first, or should it be, as Catherine says, really we're trying to do both at the same time? Do either of you, Meredith or Mal, want to jump in there?
Perhaps I could jump in first, Mark. My experience in this setting is that if we don't manage both conditions together, we find an escalation in medication use, because medication often gets used to dampen down all of that hyperarousal, that hypervigilance that goes with the PTSD, but also can be part of chronic pain as well. So you can end up in a terrible situation of high-dose medication use, which really has to be addressed before you can do anything else. Most of the medications used for managing chronic pain have significant cognitive impact around sedation, around impaired memory, around impaired processing of any information you try to give the patient, and you find you're repeating yourself over and over again, and you're going nowhere very fast. So the temptation to escalate medications, if you're only trying to manage pain,
I take the point.
I'll come. Catch-22.
I'll come to you in just a minute, Mal. But just to come back to you, Meredith, or to stay with you on that question, because actually one of the first themes we had was the overuse of medication. And I'm wondering, I'm presuming there is a place for opioids. Is there in the treatment of pain, or are we trying to steer away from them now?
There is. I guess the pendulum is swinging away from them now, and the evidence now does not support the use of opioids long term. And in fact, the evidence suggests that that is very harmful and can even in circumstances mixed with other medications, particularly benzodiazepines, potentially be lethal. So we need to be mindful of that. But more importantly, high-dose opioids may actually exacerbate pain with opioid-induced hyperalgesia. And that's somewhat hard to diagnose, but the person who's originally had a much more specific localized areas of pain might end up complaining of all over body pain. It's often diagnosed as fibromyalgia, but I think more importantly, it's often medication induced. The only way you know that that is the case is to reduce it. So the evidence suggests now that perhaps there is a place for short bursts of opioids, but to facilitate physical activity, to get people functioning again, and weaning them fairly in a very planned way towards the end of that 2 to 3 month period. You might have that person on medication. You have to have that very clear conversation with your patient, though, that that is the plan, because fear drives a lot of behaviour. And if you get to your end of your period of time with medication, you say, now it's time to wean it, you haven't put other things in place, you're going to have a real struggle, and your patient's going to feel let down and abandoned, and that is really bad for your therapeutic relationship.
Sure, absolutely. Perhaps I could bring you in, Catherine, because someone has actually written and asked about what the psychologist can do when you're seeing someone for whom you think that over-medication is a problem. And I suppose it's driven by a concern about, I don't know, maybe not wanting to question the prescribing decisions of the medical practitioner. But is there a role for psychologists in picking up on what Meredith was saying there?
Yeah, absolutely. I mean, I think often clients end up collecting a number of different medications that different practitioners may have prescribed for them. Very often new things are added without other things being removed. And there haven't been any particular goals or objectives set aside from the hope that the pain will be reduced. So often I will talk with clients about what it is that they get out of the medication that they're taking, whether they feel it makes a difference to the amount of pain that they're in. And very often the way that I'll approach it is to then have a conversation with them about, what kinds of improvement in your pain medication would make it worth you continuing to take it, and what kinds of goals would you want to be able to achieve by taking your pain medication. And so, as Meredith was mentioning, if your pain medication, if what you really want to do is to be able to go back to work, for example, but the pain medication you're taking is very sedating, then maybe the balance of the benefits and the disadvantages of the medication are such that it's worth considering a trial of reducing the medication and monitoring the progress that you're making towards the goals, so that clients have actually got some data to go on, rather than just operating on the basis that if they're in X amount of pain now on this amount of medication, the inevitable outcome of cutting their medication back is their pain is going to get worse. And it may temporarily get worse, but very often what happens, and I've seen this more times than I care to remember, is that people come off pain medication, sometimes entirely, and 6 months later they say, actually, my pain is no worse than it was when I was on the pain medication, but I feel much better in myself because I have fewer gastrointestinal problems, my concentration's better, my levels of fatigue are relieved. And often all of those things have previously been attributed to the pain condition rather than correctly attributed to the medication.
Yeah. So it's clearly, this is clearly something we need to be addressing, as both Meredith and you have said, right up front in treatment.
Absolutely, be direct.
Yeah, yeah. While we're talking about medication, I wonder if I could bring you in, Mal. I've heard it said sometimes that antidepressants can be useful in managing pain. So I guess my question is, first of all, whether that's true, and secondly, whether you've got any advice about how we might go about using antidepressants in a case perhaps with a a veteran who's got chronic PTSD and chronic pain?
Yeah, there is evidence to support that, Mark, particularly around low-dose tricyclic antidepressants, amitriptyline, imipramine in doses of around 50 milligrams a day, and also with duloxetine, one of the SNRIs. To what degree it's specific to duloxetine or it's just the one that's been studied the most is a bit unclear. The SSRIs were also looked at in pain. Generally, the evidence there isn't as strong, and at a meta-analytic level, it favours low-dose tricyclics. Predominantly, we're talking about neuropathic pain there. I think that's quite important. That creates a little bit of a dilemma in someone who's got comorbid depression or PTSD, where antidepressants can be helpful. Obviously, in PTSD, usually to a much lesser degree. There, on most occasions, SSRIs would be our first-line therapy. So if someone comes already with pain and depression, we go for an SSRI, we'll use a tricyclic, which really we'd normally avoid now for depression because of the side effect profile and danger in overdose. I've often had patients come to me already on a low dose of tricyclic for chronic pain, and that really creates a bit of a tension. That's a discussion I then have with the patient, a little bit like the sequence of therapy question. The patient should be engaged in that discussion, I think, right from the outset. Probably on balance, if I think there's a sufficient depressive illness to warrant treatment, I would be trying to use an antidepressant first line that I would otherwise use. Can they interact is an important question, and yes, they can, to produce a serotonin syndrome. The exact frequency is not entirely clear, but if I was ever seeing a patient who was on a combination of a tricyclic and an SSRI, I would warn them about the common symptoms.
Okay. So it can get pretty complicated by the sound of things. Yeah. You probably should be involving a psychiatrist with some experience in prescribing here.
Sounds reasonable.
Yeah. Just before we leave medication, let's just quickly acknowledge, if you like, the role of self-medication. And perhaps I'll come to you, Meredith. Do you come across a lot of people who are self-medicating with non-prescribed medication or alcohol or other substances and so
on? Yes, that can quite often be the case. It varies quite a lot, but you do need to ask specifically about it. Most people don't think to offer over-the-counter medications, so unless you ask, you don't know. I think the big change that's happened in Australia this year has been the rescheduling of codeine, and that's reduced some of the high-risk behaviour around over-the-counter codeine compounds, particularly related to the combinations with paracetamol and ibuprofen. So we're seeing a little less of that. I've certainly had experience where I've sat down with the patient and gone through their day and said, what do you take when? And you'd be surprised what pops out of the woodwork of, oh yes, and I just take a couple of these that I bought at the pharmacy. So that's helped, I think, reduce some inadvertent harm. Often people are taking excessive amounts of paracetamol in particular without realising it because they feel their pain is not well controlled. One of the things we know is codeine can sensitise glia. All of the opioids can do that, but to varying extents, buprenorphine is probably the least likely to do it. But some people are taking so much opioid in various forms that they don't even know how much they're taking. So it's really good to sit down with them and do that thorough history of exactly what do you take when, find out how much alcohol they take, do they use any illicit substances, any over-the-counter sleep compounds, because we know that opioids in combination with other sedative drugs significantly increase risk of impact on breathing, particularly in the context of sleep apnea. So questions about that are important as well. So particularly for our patients who are becoming more into middle age, you really need that detailed sleep history as well.
Sure, sure. and the risk of coming back to it yet again. I'm sure a lot of our veterans are self-medicating with cannabis as well, illicitly obtained cannabis. But anyway, I'm not going to go there again. Just for the benefit of the panel, we've got 5 minutes left, and there's a load of questions I'd like to get through. So I'm going to really make it difficult for you and say I just want really, really shortish and to the point answers. I'm going to turn to Catherine if I could. I'm interested, Catherine, in your thoughts on what we should do, and particularly as people may be coming off medication or at other times, when a client has an exacerbation of chronic pain, how we should manage that, and perhaps whether there's a risk of us getting a bit sucked into that. Just very briefly, you got any quick comments on that?
Well, I think the key is to foreshadow this from an epidemiological point of view. Most people that have a chronic pain problem will get intermittent fluctuations, and the problems start where people interpret those increases as being the harbinger of a deterioration in their overall well-being. So warning people ahead of time, making it part of something that they can expect, and helping them to develop a proactive plan ahead of time that they can put into place.
Right, and not getting sucked into their catastrophizing and
doing your best not to.
Doing your best not to. Exactly. It's easier said than done sometimes. I quite agree. Okay, thank you very much for that. Now, the final of the topics that was on the list there was somatoform disorders, and I think really what they're saying there, what people are asking about, we all recognize that pain is an interaction of psychological and physical kind of components, but I think people are asking about those cases that we see in front of us that seem to have an unusually high psychological component or psychogenic component. And one of our participants was asked about how you would raise that with someone. How can you raise the issue that a lot of this might be psychogenic? I don't know quite who I want to throw that to, actually. I suppose the last person not to talk was Mal, so it's probably you, Mal.
Yeah, I think that's called the short straw.
It's got a very quick answer from you, if I could.
Oh, well, I think any intervention needs to have a useful outcome. So suggesting to someone, look, I think your pain is predominantly psychological, needs to be put in a way that's actually going to lead somewhere. So I think it's pretty unlikely I'd actually use those words, but in what we do, I'd be emphasizing some of the factors that I think are contributing. So looking at what are the psychosocial factors and spending a lot of time focusing on those. If I've taken a good history at the start, that sets that up.
Yeah, absolutely. Meredith or Catherine, any very quick comments on that one?
I might just hop in because this is one of my favourite topics. I would certainly say that I don't differentiate, to be honest, because my professional view is that everybody's experience of pain is a combination of both psychological and other kinds of processes, and to try and categorize people into one box or another usually ends in tears, and not only on the part of the patient.
Yeah, I'd agree with that completely. I don't differentiate. I've not found it particularly helpful, and it's really more around helping the patient to acknowledge the influencing factors and choosing which ones they want to address, and gently guiding them in that direction.
Okay. I won't get into the dilemma of then what we do about the DSM and whether there's a whole number of couple of categories in there that we should be getting rid of. But we'll just leave that as being far too difficult.
The plan.
In the 30 seconds or so to go, Catherine, I think, was the only one who did make mention of military culture and the veteran military culture and how that might influence people's chronic pain and so on. Mal, would you have anything? There's 20 seconds left, really, but anything that you'd like to add to that? Do you think that military training, military culture makes it more or less difficult for veterans with chronic pain?
Oh, they're both good points and bad points, but people who join the ADF are very determined, disciplined and professional people. And the experience of pain and the loss of role that can often produce can be really very crippling. And I think acknowledging that loss of role and the meaning to that person is actually very important.
Okay, good answer.
And some abandonment by the system when they're no longer functional.
Yeah, exactly. Thank you very much indeed to all of you. The time always goes so quickly on these webinars, and I'm really disappointed that we haven't got more time to explore these issues in more detail, but I think we've done a reasonably good job. What I would like to do now is to ask each of our panelists if they've got any very brief take-home messages, any final points that they'd like to make sure that participants leave with. And so I might turn to you first, Meredith. Any final take-home messages for our participants?
I think a really important take-home message is not to abandon the patient. So many patients feel abandoned by their healthcare practitioners when they get to the limits of their experience. So to be able to say, I don't know the answer to that, but I'll find out and follow up diligently is really important. Pain is complex, and acknowledging the individual personal experience is really, really important. And then working well with the team is absolutely essential.
Good. Thanks, Meredith. Catherine, any take-home messages?
Yes, I was going to say that I think really chronic pain is best managed as part of a team with the client and the various different disciplines who are involved. And if you're not part of a team, make a virtual team around every client. I think it's good for everybody to be working together and making sure that the psychological issues are applied by all of the members of the team.
Good advice. Thank you, Catherine. Mal, any takeaway messages?
I'd agree with those, and part of that team's capacity is to really establish a good history and sense of all the domains and issues that are relevant right from the start. I think that leads to the best treatment planning. And of course, as part of that, don't forget psychiatric comorbidity.
Sure. Absolutely. All right, good. Thank you very much indeed to all of you. I've just got a few closing comments that I need to make. First of all, MHPN runs peer networks across the country where multidisciplinary teams can get together and chat about a whole range of cases and referrals and that sort of stuff. And recently, MHPN has started specific veteran-focused ones, and you can see there on the screen where they are. So if you'd like to join one, you can click on the relevant tab in the resources section. And if you're interested in starting one, then get in contact with MHPN and they'll help you do it. I think they're a tremendous way for clinicians to support each other and help each other through. There is, as we said, a number of resources available to support this webinar. And we will send around a link to those resources shortly, within the next week or so. I would particularly draw your attention to the DVA at Ease website, because I think it's really good. Loads of good information for veterans, their families, and for practitioners. So that's worth a look. But there'll be a whole lot of good resources here, including the slides from tonight and resources recommended by our panel and also by DVA. So finally, if I could just ensure or encourage you to complete the feedback survey before you log out. It's really important that we do get your feedback on these webinars so that we can make them better. You're going to get certificates within 4 weeks. But at that point, I think at this stage, I'd really just like to thank very much indeed our three panelists, Meredith, Catherine, and Mal, for a fantastic input tonight. And also, I'd like to thank you, our participants, for your engagement. The numbers have been fantastic. We're well up over 1,000. And the questions that you've sent in and your engagement makes it all so much better. So thank you very much for your participation. Good night to you all. Good night.
Good night.